be able to give you a great synopsis of how to actually manage an asthmatic patient in a pediatric emergency room and add just a little bit more information to the literature, the supporting literature that I have here in my lecture. So today's objectives are going to be for you guys to diagnose and manage asthma in the pediatric ER. I want you guys to be able to know the essential therapies as well as adjunct therapies in treating asthma. I want you to be able to classify asthma as well as to be able to interpret the severity of asthma. Lastly, we're going to discuss risk factors for death and when we should intervene an asthmatic patient. So according to the CDC in 2017, asthma was actually the most common chronic disease in childhood. It affects about 6.2 million children less than 18 years of age. And that's about 1 out of 11 children in the United States. Young children are more likely to be diagnosed with asthma, and it's more prevalent in westernized countries, however more severe in developing countries. And it does have a seasonal exacerbation pattern. It accounts for more than 2 million ED visits per year. And when you look at the medical records in the emergency room, it accounts for 10.1% of the visits in the emergency room. It costs about $11.5 billion per year, and it's estimated that 1.1 per 100,000 deaths occur. Adolescents and unvaccinated Black children are at risk of fatal exacerbations. This point right here is actually very interesting because it was actually a study that came out from the American Journal of Respiratory and Critical Care, and it found conflicting evidence with this fact. The study actually found that after adjusting for multiple risk factors, the high prevalence of asthma among Black children is not due to race or low income per se, and that all children living in urban areas are actually at high risk for developing asthma. It just so happens to be that Black patients happen to live in urban communities, and so that's why there's a strong correlation there. Either way, whether we say this fact is true or not true, we do serve an urban population here at Kings County, and we do serve Black children, so we should take extreme precaution when we're treating our asthmatic patients. Now, briefly, I just want to talk to you a little bit about the pathophysiology. So there's numerous phases in asthma. The first phase is the bronchoconstriction phase. It's caused by a release of mast cells, such as histamine, prostaglandins, leukotrienes, that give rise to mucosal edema and increase mucosal secretion. This in turn increases smooth muscle tone and causes bronchospasm. This results in airway narrowing. And then you also have your inflammatory phase, which is caused by an overly robust immune response. Basically, the lung parenchyma is infiltrated with a host of immune cells, such as eosinophils, basophils, neutrophils, T helper cells. These cells then potentiate mucosal edema and increase mucus production and smooth muscle contraction, resulting in worsening of the narrowing of the airways in asthma. All these phases together result in airfield constriction. And during this time is when you start seeing a VQ mismatch. And this is because there's an issue with ventilation with the normal perfusion of the lungs. All right, so when you're looking at an airway using a bronchoscope, the left picture is actually a normal airway. You see it's nice and pink. It looks like healthy tissue. Over to the right, you see an airway that's narrow due to inflammation. It's kind of red, it's boggy. This is what your typical asthmatic patient would actually look like if you were to use a bronchoscope and look at their airway. And it's really important because individuals with asthma have intrinsic airway hyperresponsiveness that can be triggered by multiple things. Some of the things are like common environmental agents, pollutants, viruses, such as any of your respiratory infections that will cause a common cold, changing weather, exercise symptoms as well, smoke. If they have family members in the household that smoke, this will easily trigger their asthma, as well as emotional stressors. We don't really talk too much about emotional stressors, but kids who are very anxious or have psychosocial issues at home are more likely to have severe asthma. All right, so So now I want to talk to you guys a little about how we would evaluate someone with asthma in an emergency room. There's two categories of patients that you may see. There's going to be a patient with an already known diagnosis of asthma and one who's a first-time wheezer, or maybe someone who's coming in with multiple episodes of wheezing but has never actually been diagnosed. And so you want to make sure you're getting a really great history for these patients. And so for your patients who are coming in with no diagnosis of asthma, but maybe first-time wheeze or multiple episodes of wheeze, you want to make sure you're asking that. Is this the first time you're wheezing? Or is this the first time your child has wheezed? If the mom says no, you might want to ask them about triggers. Do you notice that this child wheezes when they're sick? Do you notice that they wheeze when they're at dad's house, when they smoke around, when there's cats around? Those are all important questions you want to ask. You also want to try to get an idea of whether this patient has a response to albuterol. So if they're not actually diagnosed with asthma, but they have had albuterol before and they were responsive, this would imply that maybe this child is truly asthmatic and maybe we need to go ahead and give them this diagnosis. You want to inquire about daytime and nighttime symptoms as well. Are they coughing at night when they're not sick? When they're running around, do you realize that they can't keep up with kids their age? They're coughing or complaining of chest tightness. These are all also important questions. And then you want to ask about HB. Does the child have any eczema? Do they have allergies? Whether they're seasonal or not? Is there a family history of HB or asthma? And that would be really important for these patients, specifically because it increases their likelihood of actually having asthma. And then lastly, you want to ask about medications. Were they ever prescribed albuterol? Because some parents would say, my child has never been diagnosed with asthma, but they do have albuterol at home, which means they may have at least tried it. And it can be confusing for patients because we do give nebulized albuterol as well as just like saline. And if you ask as a child who received treatment, they may not know whether it was albuterol or whether it was actual just a saline treatment. Now, when you're talking about children who are established with diagnosis of asthma, you want to ask them some similar questions, but really you want to know what the triggers are, especially if they've had it for some time. A lot of times they know what triggers it. Like, yes, my child always starts coughing and wheezing when they get sick. Or yes, when the pollen's really high in the air, my child starts having their asthma exacerbations. You want to ask about daytime and nighttime symptoms. This is daytime cough, daytime wheeze, or nighttime cough or wheeze when they're not sick. You want to ask about exercise symptoms, if they're able to keep up. And then you want to know what medications they're taking. What are they prescribed? Do they just have a Asthma inhaler at home? Do they have an inhaled corticosteroid that they're also using? Are they compliant with their medication? How often do they use their rescue inhaler? And how many times have they been prescribed systemic steroids over the course of the year? These are all important questions because you want to try and assess the severity of your patient's asthma. Another important question is ICU admissions. If they have a history of intubation, the number of ED visits they have in the past 12 months, as well as the number of hospitalizations they've had in the past 12 months. These are also very great predictors of how severe your patient's asthma is. And so why is this important? This is important because multiple studies have shown that there are risk factors for patients who suffer from asthma. This study in particular showed that the risk factors that included history of near fatal asthma, chronic intubation, or mechanical ventilation, hospitalization, and ER visits, as well as patients who are currently using steroids or recently stopped using steroids. If they have a history of psychiatric disease, it put them at increased risk. Surprisingly, if they have a food allergy, it put them at increased risk. And if they just weren't aware of their asthma or the severity of their asthma, that obviously would put them at increased risk. This other article is from the Pediatric journal, and it was really just assessing the psychosocial factors that affect asthma morbidity. And in here, they found a strong relationship between mental health in children and asthma. And children with significant behavior problems had significantly more days of wheeze and poor functional status. Surprisingly, they also found that in patients who had parents with severe mental illness, they were also likely to be at increased risk for having poor asthma outcomes. So this is just to bring home what I was saying, risk factors for death, previous ICU admissions and intubation, if they're having more than 2 hospitalizations or beatings in the past 12 months, if they're using their short-acting beta agonists, more than 2 PMs within 12 months, that is a risk factor. If they're in denial or they don't understand the severity of their illness, if they're not compliant with their children medication or the asthma care plan, if they have a poor socioeconomic status, other comorbidities such as mental health issues, and if they're African American or Hispanic descent. Again, this last bullet point is questionable as conflicting evidence, but still we should be aware of it. So back to evaluating your patient. Once you obtain a great history, you want to get a good physical exam. What's really important here is your vital signs. For children who are static less than 92% and coming to ER, these kids are more likely to require progressive treatment and also more likely to require admission. So you want to make sure you're paying close attention to their vital signs, the saturations. These patients typically come in tachycardic and to get them. You want to look at the general impairments. Do they look like they're respiratory stress? Are they retracting, belly breathing? Do they look like they're having shortness of breath? Are they putting themselves in a position of comfort to help them open their airways and breathe better? And then, of course, respiratory. You want to be able to auscultate these patients. See if they're wheezing. Are they having just expiratory wheeze? Is it biphasic wheeze, meaning both inspiratory and expiratory? Are they having a prolonged expiration? Or is their chest completely silent? A silent chest is actually an ominous sign, and those are the patients that you really want to worry about. You may say, hey, they're not wheezing, I'm not sure if you're in the asthma pathway, but it could be that they're so tight and so obstructed that you can't hear wheezing at the time. And then another really important thing is checking their mental status. Are they altered? Are they more tired, fatigued than normal? Was there a change in their mental status? These would all be signs of impending respiratory failure, and reasons we want to pay close attention to their mental status throughout the entire visit in the ER. So this, I just put up here for some of the new interns, and anyone here who has never seen this before. This is the Pediatric Asthma Severity Score, and it's a more objective way to be able to categorize your patients in the emergency room when they come in, to determine whether they're having a mild asthma attack, moderate, or severe. And it's categorized by respiratory rate, oxygen requirements, auscultation, retractions, and dyspnea. And so what you do is you tabulate and you kind of score your patient. They would be having a mild exacerbation if their score was from 0 to 7, moderate if it was from 8 to 11, and severe if it was from 12 to 15. As far as diagnosing asthma, it is a clinical diagnosis, and the clinician should be able to determine that by knowing these few things. If the patient is having episodic symptoms of airflow obstruction or hyperresponsiveness, or as well as their airway obstruction needs to be partially reversible. And then you need to make sure you're excluding any other cause of wheeze, whether that's foreign body, bronchiolitis, viral infection, anything of that sort. Once you decide that they are having some kind of airway hyperresponsiveness and it is partially reversible, you want to get a detailed physical, you want to get a detailed medical history, just kind of like we talked about before. Other things that might be helpful, we don't really use in the ER, is looking at their FEV1. Typically for us, we use the peak expiratory flow, or PEF. That is more helpful for us in the emergency room. And then if you think you need to get chest x-ray or additional studies to exclude any alternate diagnosis. If you still feel like you're having a hard time diagnosing this child, you can think about the asthma predictive index. This is an index that requires them to have 1 major criteria and 2 minor criteria. The major criteria would be a parent with asthma, diagnosis of atopic dermatitis, or evidence of sensitization to environmental allergens. If they have one of these, you want to start having high suspicion. And then 2 of the following: evidence of a food allergy, they wheezed prior to having, they're having wheezing without having like a viral infection or a cold. And we don't typically get labs in our asthmatic patients or patients who are in severe respiratory distress, but if you do have these labs, you may say they have eosinophilia. In general, though, there is no indication for chest x-ray and acute asthma exacerbation. However, you can't consider it in a febrile patient if the temperature is greater than 39 degrees Celsius, if they're very hypoxic. If you find out they're having focal abnormalities on exam, Typically, your asthmatic patient is going to wheeze kind of everywhere. It's going to be diffuse wheezing. It may even be a little bit scattered, but it's not going to be focal, like right lower side of wheezing only, typically. And you also want to make sure, you also want to get a chest x-ray if there's no family history of asthma. I'm not saying that your patient can't be an asthmatic without having a family history, but it might be a reason why you want to obtain one just to make sure you're not missing an alternative diagnosis. And then another reason would be if you're actually treating this child and they're not getting better with albuterol, you may say, hey, I think we should get a chest x-ray. Maybe I'm missing something. Maybe it's a foreign body that's causing it, or maybe it's pneumonia. Like I said, in the ER, we do use peak expiratory flow. These are the formulas that we actually use. You don't need to remember these formulas. You can actually log on the internet with an account, put in your child's height, weight, and age, and it can tell you what their expected peak expiratory flow is, and you can use that as a predictor of how severe their asthma is. All right. So the other thing is classifying asthma. This chart's a little bit busy, but there's a really easy way to learn it. The two categories of asthma are intermittent or persistent, okay? And just remember the rules of twos. The rules of twos will be able to say, if you use the rules of twos, you'll be able to say, okay, this child's intermittent or this child's persistent. So if your child's having symptoms less than 2 times a week, nighttime awakenings less than 2 times in a month, using the short-acting beta agonist less than 2 times in a week, and not having any exercise symptoms or it's not affecting their normal activity, you could say, okay, this child is a child with intermittent asthma. Now, if they're having more than 2 of these symptoms, whether it's more than 2 symptoms per week, more than 2 symptoms of nighttime awakening, or they're using their albuterol more than 2 times in a month, then you say this child's persistent. And then persistence broken down into mild, moderate, or severe. And basically, mild would be just greater than 2 times. Moderate would be if they're having daily symptoms, and severe would be they're having symptoms throughout the day. Once you categorize them, you want to make sure you know if they're controlled or not. So if your child comes in and you know you look at their chart and they only have albuterol prescribed, or mom says they only have albuterol prescribed, but they're having symptoms more than 2 times a week, you can still use the rules of twos for this as well. You would say, okay, maybe this child is not a well-controlled child, maybe they're partially controlled. So as far as control, partially controlled, or uncontrolled, once again, remember the rules of twos in terms of daytime symptoms, nocturnal symptoms, and use the rescue inhaler. All right. And so now I'm going to move on and talk to you a little bit about how we can actually treat asthma. So you have your essential first line medications that we're all pretty much familiar with. We're going to go through them briefly. You have your inhaled beta agonists. These would be things like lead albuterol, albuterol. They can be given via MDI or nebulizer. Your beta agonists are bronchodilators. And once you administer this medication, you may see a temporary PQ mismatch. And this is because there is a quick reversal of the hypoxic-induced pulmonary vasoconstriction when you use these meds. And as far as dosing goes, typically you would dose your patients at 0.15 to 0.3 mg per kit, up to 10 milligrams per treatment. At Kings County, we keep it really simple. We just do it by weight. If you are less than 20 kilos, you're going to get 2.5 milligrams. If you are greater than 20 kilos, you're going to get 5 milligrams. And then you have your inhaled anticholinergics. This obviously is something like your ipratropium. It works by blocking your cholinergic receptors and reducing bronchoconstriction. And it's only typically effective in the acute setting. And then you have your systemic steroids that you can give. Your systemic steroids work by suppressing inflammation at the cellular level. They're really helpful because they're supposed to help potentiate your beta agonists. So you want to dose this appropriately. Make sure there's different kinds. There's different kinds. You have your oral, your IV, or your IM. Your oral includes things like prednisone, vernisolone, which is tab versus liquid. Then you have your dexamethasone, which you can give an IV, IM, or oral. And when you're talking about dosing, you want to do a loading dose of 2 mg per kg with a max of 60 if you're doing oral pred. And if you're using Dex, it would be 0.6 mg per kg, max of 16. All right, and then you have your adjunct meds. Your adjunct meds are your second line meds. If you have a patient who is refractory to their first line treatment, their essential meds, then you want to start reconsidering other things like epinephrine. Epinephrine has good bronchodilator, is a good bronchodilatory medication. You give this sub-Q, and the dose for that is 0.01 mg per kg. And you have magnesium. Magnesium works on the calcium channel blockers, so it enhances smooth muscle relaxation. And you would give this. The dose for that is 25 to 75 mg per kg. You also have your TERB. TERB is also beta agonist, but it can be given both sub-Q, IV, or as a drip. And then ketamine. Ketamine is an amazing drug. We don't use it as much in the pediatric patient, but it's something you should consider in your real anxious patients, especially patients who are anxious to the point where like they can't keep their mask on, or if they're just refractory to other medication. They're having refractory symptoms after other treatments. Ketamine actually has good is a good bronchodilator. It also may have an effect on bronchuria, reduces bronchuria, and it's really a good drug for RSI, or rapid sequence intubation. And this is because it decreases your risk of cardiopulmonary arrest, and it doesn't really affect you like your other RSI meds in terms of hypotension. The one thing that you do have to worry about in these with ketamine though is that if your patient has a history of seizures, it does lower the seizure threshold. So you may just want to be careful with that, but of course their weight is always first. And there's also like an associative effect with ketamine. However, the good thing about it is that if you give that dose of 0.5 to 1, you can get all these respiratory effects without worrying so much about the emergence or dissociation that is correlated with ketamine. Now, I talked about systemic steroids already, but I really want to make a big point and talk to you guys about dexamethasone versus pred. Primarily because when you're in the ER, you may be in debate thinking like, should I give Dex for this patient? Should I give oral pred for this patient? Which one is better? You'll notice, however, in our pediatric emergency room, we use a lot of Dex. And this is because multiple studies have shown that there's actually no difference in how it affects our asthmatic patients. This study right here was actually looking at how it was related to persistent symptoms, quality of life, admission rates, and unscheduled media term visits, and it found that whether the patient was given dexamethasone or prednisone, there was no difference, and that dexamethasone was as effective as a 5-day course of oral pred for acute asthma. This study was actually looking at a single dose of dexamethasone and actually had very similar findings. They looked at kids between the ages of 2 and 16, and they realized that dexamethasone was actually tolerated a lot better. It caused less vomiting in our asthmatic patients, and they were more adherent to it because it was just one-time dosing versus daily dosing when you're using oral pred. And then this last study, once again, just driving that same thing home, single dose of Dex for moderate and severe pediatric asthmatic patients. It showed a lower admission rate when using dexamethasone when compared to oral pred. Those who were given dexamethasone, only 17% were admitted versus 24% who were given oral pred. All right, so besides medication, if your patient is still refractory and still tachypneic and still having increased work of breathing, the other thing that you want to consider with your patient is oxygen. They need oxygen or Heliox. Heliox is a mixture of helium and oxygen. It's really a good medication or a good inhaled or a good way to give oxygen because it decreases turbulent airflow, the Heliox does. It enhances laminar flow and thereby reduces airflow resistance through narrow airways. And it's thought that increasing the laminar flow will actually reduce your work of breathing, and it also promotes inhaled drug delivery. This may improve respiratory distress and prevent respiratory failure in a select few patients. The only issue with this is that if you have a child who is requiring a lot of supplemental oxygen, HELAX doesn't work well if you need an oxygen concentration greater than 30%. So at that time, you may want to consider something like BiPAP. BiPAP is actually really great because it has a great bronchodilator effect, and it promotes peripheral bronchodilation while removing fatigue expiratory muscles. This offsets the auto peak that your patients kind of generate on their own when they're in severe respiratory distress. And in turn, recruits collapsed alveoli, causing a reduction in work of breathing and improving total lung capacity. The one thing I do want to mention to you is how you would start. So your initial settings can be anywhere between 12 and 16, just depending on work breathing your patient and their age and their size. And then your EPAP would be 6 to 10. You do want to increase their I-E ratio, however, because patients have a hard time depleting their lung volume. They have a prolonged expiratory phase because they're trying to get air out of their lungs because they're air trapped. So this is why you want to do that. And you want to have low backup ventilation rates. This is a study just for use of BiPAP in pediatric ED. It's by the British Medical Journal. This was an 8-year analysis of quality improvement. It was a quality improvement program for BiPAP, and it was used in the PED for severe asthmatics. It included 1,157 patients, and basically showed that BiPAP was really safe with no expected or unexpected complications, and that it was tolerated in all ages. I know a lot of times we're concerned that depending on the age of the child, they won't tolerate BiPAP, but this study actually showed that there was no issue with that. And I also went over the optimal settings of BiPAP, which is kind of what I went over with you in the previous slide. The study also showed that in patients who had BiPAP started in the ED, they were less likely to be intubated. They had decreased PICU admission rates and a shorter PED BiPAP course. Some of them were actually able to come off BiPAP in the emergency room, and the BiPAP did not have to be reinitiated, and some were able to go home afterwards, after it was started. This study is a study that had similar findings. They looked at 201 patients, and they stratified by moderate and severe asthma. It really showed very similar findings to the previous study. It showed that it was beneficial. It was a beneficial therapy for children in the pediatric emergency room, and that there were no complications with initiation. And the questions that we all like to ask each other, after all of these things fail, you've given your meds, you've given your oxygen, you've given your BiPAP, and your patient still looks like they're in severe distress, you ask yourself, should I intubate this patient? There are indications for intubation. If your patient's having poor response to therapy, like I said, this is when you start considering it. If they're having a rise in their CO2, like a CO2 greater than 50, you would consider it. If they're severely hypoxic, if they're having mainly mental status or fatigue, you think that they're having impending respiratory arrest or cardiac pulmonary arrest, these are all indications for you to go ahead and intubate your patient. The one thing I will say though, if you decide you want to intubate an asthmatic patient, you do need to make sure you're prepared for it, okay? You want to put oxygenate the patients. You want to make sure you establish adequate IV access. You want to consider fluid boluses to prevent acute hypertension. You want to make sure you have your ET tube ready. And like we discussed earlier today, you would want to make sure you have the appropriate size for your patient. And for pediatric patients, it's age in years divided by 4 plus 4. And it's really a good thing to actually have a tube that's half the size down, just in case the initial tube you have is a little bit too large. And then at that time, you can consider getting your rapid sequence intubation. When you do this, you want to use ketamine. Ketamine is a great drug for asthma. Like I said before, it has good bronchodilatory effects, and you decrease your risk of cardiac pulmonary arrest, which is really what we're concerned about when we think about intubating asthmatic patients. And then you want to consider a paralytic, whether it's going to be SUX or LOC. SUX actually has a high side effect profile. It can cause hyperkalemia, malignant hyperthermia, and bradycardia. Raw is fairly safe, and it has very few side effects in comparison. However, it does have a prolonged duration of action compared to sucks. So a lot of the times, people choose to use sucks in these patients. Other things to consider are atropine. I've never actually done this before, but I was reading that atropine is really good to give in asthmatic patients if you want to try to prevent laryngeal spasm. And you can also consider lidocaine. This helps diminish the effects of laryngeal spasm. So when you intubate your patient, you want to make sure you're reaching certain goals, okay? You want to make sure you're keeping your patient above 91%. You want to be able to allow for some permissive hypocardia, and then you want their pH to be greater than 7.2%. When we're talking about vent settings, volume control mode is the best mode for them because you want to prevent barotrauma. And also, like I previously stated, they have an issue getting air out of their lungs. So at that time, you really want to make sure you're setting your ventilator rates really low, and you're giving a prolonged expiratory phase. For our pediatric patients, you want your tidal volume to be between 5 and 6 mils per kid, and then your rate should be half normal for age. You want to have very low peaks when you're doing this. And like I said before, short inspiratory time. This helps minimize dynamic hyperinflation as well as air trapping and barotrauma. So when you intubate any patient, if you realize that your patient is starting to deteriorate, you want to evaluate for a few things. And the mnemonic you should use for this is DOPE, D-O-P-E. You want to make sure your tube is not displaced. You want to check and make sure the tube is not obstructed. Is there a lot of mucus plugging? You need to change out the tube. And then P for pneumothorax. Did you give a pneumothorax when you were intubating, or is there equipment failure? And then if all these things, you kind of ruled out, you want to think about other things that intubating can cause, like hypertension, DSATs, pneumothorax, subcutaneous emphysema, tension, pneumo, cardiac arrest, and cardiac arrest. All right. So I'm going to try to summarize everything for you briefly using this clinical pathway for the management of asthma. When you have a patient come in wheezing, like I said before, you want to make sure you get a good history and physical. You want to check your vital signs. You want to get a peak expiratory flow on them. You want to assess the severity. If your child is having a mild exacerbation, their peak expiratory flow will be greater than 70%, and they shouldn't really be having much limitation of activity. This is a patient you can just give maybe albuterol to, plus or minus an oral steroid, and if they're okay, you can discharge them home safely. If your patient is in moderate distress, and they're having dyspnea with activity, this is when you want to start considering things like ipratropium, albuterol, and an oral steroid. And then if they're in severe distress, and they're having dyspnea arrest, you want to start thinking about your same treatment, your inhaled beta agonist, your inhaled anticholinergics. Then you start thinking about maybe IV or IM steroids, primarily because if they're really tachypnic and having a hard time breathing, you don't want swallowing to be an issue for them. All right, so this is just kind of the pathway continued. Mild, you can discharge them with inhaled beta agonist plus or minus an oral steroid. Moderate, if their symptoms resolve after you've treated them, you can also discharge these patients home. However, if their symptoms persist, then you want to start thinking about your adjunct medications, and you want to consider IV MAD. After giving MAD, if their symptoms improve, you can admit them for frequent inhaled beta agonists and steroids, or if their symptoms completely resolved, you can still send these patients home as long as they have great follow-up and they're with a trustworthy feeling. If you administer MAD and your symptoms persist, you want to start considering things like your IV epi, your TERP, and your ketamine. There will be patients that come into the pediatric emergency room who are in severe distress, and you don't even need to take it, you don't need to go through this pathway as a step-by-step process. You're just going to throw the entire stick at them and hope they improve. But if you're doing a step-by-step process, the next thing you want to consider is if they need respiratory support. So if they don't need respiratory support, you can go ahead and admit this patient to the ICU. If they do need respiratory support, that's when you want to start considering things like Heliox or BiPAP. If they improve after that, get them into the ICU, or if they need additional support, then you want to intubate this patient and send them to the ICU. So for those patients who actually make it home, discharge criteria is really important for you guys to know, because we worry about the patients that we send home, not the patients that are here in the hospital that we keep an eye on. So you want to make sure that they're no longer having symptoms. You also want to make sure that their peak flow is back at baseline. And if their patient doesn't know what their baseline peak flow is, you want to make sure it's ideal for their age, weight, and height. You want to make sure they're able to tolerate albuterol every 4 hours, and that they are able to monitor or manage their asthma at home. You want to make sure they have appropriate discharge medications, as well as appropriate inhaler techniques for using a spacer. A lot of our pediatric patients come in and they had a spacer but don't realize how important it is, or they lost their spacer, so you want to make sure you're bringing these things up and teaching them how to use it. And then you want to make sure they understand the asthma action plan. We don't typically give out like a handwritten asthma action plan in the emergency room, but we do give out discharge instructions. And if you want to print out an asthma action plan for them, that would be great, especially if they're on multiple medications. And then you want to make sure you're giving out clear written and verbal return precautions. And allowing them to have follow-up within 40 hours from discharge. So briefly, I mentioned that you want to make sure that your patient has the appropriate medication when they're being discharged from home. And I want to talk to you guys about a few studies that I found about initiating inhaled steroids in the pediatric emergency room. Typically, when you're talking about starting any type of control of medication, a lot of ED physicians are actually are not comfortable doing it. They're not comfortable because they feel like it's a primary care physician's job to actually classify an asthmatic patient and start the inhaled corticosteroid. Others worry that if they start it, once they follow their PCP, no one's going to maintain it and write a prescription. And some are just not really comfortable prescribing it in general at all. However, here at Kings County, we do classify asthmatic patients, and we do start inhaled corticosteroids in our ER, which I think is very important because multiple studies have showed that it can help long term. This study, this is a study that was actually in the Annals of Emergency Medicine. It was looking at whether or not patients who were prescribed inhaled corticosteroids in the ER had their prescription maintained once they left. What they did was, it was a randomized control study. They had a group of 147 patients, randomized into 2 groups. One group got the inhaled corticosteroid from the ER, the other group did not. Both groups were treated exactly the same and given great discharge instructions and return precautions. And it found that those patients who were actually prescribed inhaled corticosteroids in the ER were more likely to have a prescription maintained by a primary care doctor and more likely to actually be prescribed in those who are not. And there was no statistical significance when we were looking at asthma symptoms, quality of life, or follow-up. However, they did find that children who were prescribed inhaled corticosteroids in the ER had 2 fewer days of daytime shortness of breath and nighttime cough, which is really important for us. This study actually took it one step further, and they had all their providers prescribed inhaled corticosteroids in the ER, but then they provided a written asthma action plan in addition to that. And what they found is that those who received the written asthma action plan, they were more adherent to their medications. That being said, that was adherent to their inhaled corticosteroid that was prescribed in the emergency room, as well as their albuterol treatments. And they had better follow-up, and their quality of life was actually improved. So lastly, I just want to end with discharge instructions for your patient. This slide is actually just a screenshot of your asthma discharge instructions that we give here at Kings County. So everyone here should be really familiar with this. If you haven't been in the PCR yet, you will be. These are the instructions you'll be giving all your asthmatic patients. The first line is just talking about medications they should be using at home. You want them to make sure they're taking albuterol every 4 hours, at least for the next 48 hours, and then as needed for these. And then the asterisks here are used just so you can add in any medications that you're going to prescribe, whether that's Dex, whether you're going to go ahead and start inhale corticosteroids, or whatever else you're starting the patient on. And then the section talking about wheezing, preventative measures, and then the very bottom is once you return to the ER. These are things we want to make sure we are verbalizing to our patients always. Make sure you're talking about, make sure you discuss with them when they should come back if they're breathing difficult, if they have difficulty breathing, if they're breathing too fast, if they're having contractions, they're complaining of severe chest pain, their child looks unusually sleepy or drowsy, they're pale in color, they can't speak in full sentences, or if the parent's just worried just in general. So in summary, you want to make sure you're establishing their diagnosis. You want to make sure you're determining the severity of your patient, asthma. You want to identify triggers. You want to start your meds and make sure you're educated upon discharge. And this here is just a picture of an asthma action plan that can be, you can print out for your patients, and it's just a discharge summary where you fill in the meds for the patient, and that way they have something else in addition to just the written instructions. They have something that's more visually appealing to them, so that they're actually taking care of their asthma at home appropriately. So in summary, you can avoid diagnostic testing for acute asthma. You want to consider Dex versus Orphan for acute asthma exacerbation. You want to consider adjunct therapies for refractory acute asthma acute exacerbations. You want to initiate inhaled corticosteroids that didn't mature in the ED. And you want to make sure you're providing clear term precautions upon discharge. These are my references. You guys have any questions?
That's been very good as far as covering everything and having all those studies. That was very well put together. I just want to emphasize something you said for adults as well. When I see an adult and they get discharged, someone who I had to keep in the ER and treat and start steroids in the ED, when I discharge them, I always discharge them with a rescue pump. Albuterol is what we all use. And I also, discharge them on steroids, usually a short course. Like if I'm using prednisone, I'll usually give them a 7-day course. And don't taper it. There are studies that show you don't taper it if it's less than 10 days, 2 weeks. You don't have to. And then I will start Flovent from the ED. Always. There's some good studies from the NIH for anyone who has to use their rescue pump more than twice a week, or anyone who's bad and having to come into the ER and stay for a while, that they need to be on an asthma pump, even adults, and a controller pump, not just a rescue. So I use my control Flovent, and then get them into the clinic as soon as you can. So I like that you emphasize that, because I think a lot of people say, well, let's leave it to the primary. No, you can start it right there, so by the time you finish your steroid course, they have something that may control their asthma, control the pump.
Yes.
Do you know if there's any data supporting advanced doses of 16 milligrams rather than 10?
You know what? I didn't actually look into specifically like max dosing. I know we talked about 16 versus 10 and what you're comfortable with. There, from my knowledge, there's nothing that supports one or the other. I think that it may just be more of a comfort thing or what we're used to, but I'm not 100% sure. I can always look further into it for you. I know we do different things. I know you guys do 10 in the adult. It's kind of weird to do 10 in adults and 16 in children. So this is what it is. Like, anybody else? Any other questions? Yes. Yeah, so there's studies that talk about, so basically your question is whether a single dose is as effective as a multi-dose? Okay, so there's studies that do support that a single dose of Dex is as effective as a 5-day course of Orphan. But there's also studies that show like you can do a multi-dose. So if you're really concerned about your patient and your patient's been having asthma symptoms for days now, has been using albuterol constantly for the past 2 days, has been to your emergency room multiple times, then you can also dose the second dose just to kind of lengthen the duration of steroids in their system. So at that time you could do Dex in the ER, but then at 48 hours just do a one-time redose. But if you're only talking about a 5-day course, to say do support and say that a one-time dose is equivalent.
I'll just make 2 comments to address those 2 questions. I don't think there's any true evidence as far as the 10 versus up to 16 dexamethasone. What I usually kind of go to potentially support the 10 is, well, A, you're maxing out on that, and most of the adults that probably is good enough. And then if you look at like a conversion table with the, the steroid dose converters between dexamethasone versus, prednisone versus, betamethasone or whatever, it basically, you get to 10, when you get to 10, you're already at something like 60 of prednisone. So 10 is probably okay on that. The only other thing about these studies with the DEX, I mean, I love DEX and everything. When you do look at the studies and the population that they're using, many of them are these mild to moderate asthmatics. And so based on that, I know John does the same thing. If you've sat with that kid for a while in your ED, then you probably want to give them, and you were, maybe considering admitting them, they should probably get a second dose. Because when you look at the population, that they actually looked at them on, yes, they showed that they were equivalent, but again, if they were not so horrible to begin with, that second dose doesn't really matter. That's, yeah.
Don't get 216 milligrams, please.
Oh, there is good evidence that the PO steroids is equivalent to IV. So that's
Bioavailability is the same, no matter how you give steroids.
Just important to note when these single dose studies, the dose was 16 milligrams. It wasn't, I haven't seen, but look, I didn't see any studies where the dose was 10 or 12, physiologically, or explaining makes sense, but all the studies and evidence that we talk about, that was using 16 milligrams. We use single dose.
I think
When I was looking for 10, 12, I didn't find